on this computer. Okay. All right. Good morning, everybody. It's nice to see your bright and shining faces. Oh, good. I can see more people now. Hi, Hannah. Hi, Erin. Lavi, Jen. Yay. Allie, Kristen. Okay, awesome. So what we're going to start out with, we're actually going to try to stay a little bit in order in the course pack. And we're going to start out with the theories and therapies, treatment modalities. So hopefully you tried out the matching assignment so that you can kind of follow along and see how you did on this matching. If you didn't try it yet, then I would just recommend writing down the answers so that you can go back and double check yourself I wouldn't just fill them in, because that's not going to help you, make sure that you know what these all mean. So under chapter 3, the matching, is everybody good with that? You guys are all there? Yeah, okay. Good.
Yeah.
See some head shaking. Very good, thank you. Number 1 is Q, 2G, 3J, 4E, 5H, 6R, 7B, 8K, 9M, 10A, 11P, 12L, 13C, 14I, 15F, 16N, 17D, 18O. Okay, were there any questions about any of those? Any of them you want me to explain further?
No, I was good.
Good. See a lot of heads shaking no. Okay. All right, so chapter 4, matching. I will tell you that for these, a lot of this is meant to be review, and it will help you with understanding the medications, but there's not going to be a lot of like direct testing on this information. A lot of it's more just trying to understand then how the medications work and how they affect the neurotransmitters, all that. So number 1 was G, 2L, 3J, 4I, 5K, 6B, 7D, 8N, 9F, 10A, 11E, 12H, 13C, 14Q, 15O, 16M, 17P. Did you miss those first ones, Maria? Okay. 1G, 2L, 3J, 4I, 5K, 6B. Good? Okay. Awesome sauce. So, sorry, my allergies are acting up. So now we're going to talk about prominent theories and therapeutic models. We actually have touched on some of these because you've learned about bipolar disorder and especially with depression, so you might already have an understanding of some of these. When we look at psychoanalytic theory by Freud, so this is really our oldest model that we have. It's not that we really use Freudian theory a whole lot, it's that a lot of other models are then based on it. So it is actually important to kind of have a basic understanding, and there are a few points that he made, so many years ago that actually do still kind of stand true. So it can be helpful to understand. So claims that most psychological disturbances are the result of early trauma or incidents that are not often remembered or recognized. So that there's a lot of what this theory is about is trying to pull those early traumatic events and things that happen, trying to keep those from being repressed. So we look at the 3 layers of mental activity. So our conscience is what we are currently aware of, thoughts, beliefs, feelings. It's the tip of the iceberg. It's influenced by the preconscious and the unconscious. So what we would think about with your conscience, hopefully right now, is Freud. It could also be, needing to go to the pharmacy or needing to go get groceries or what your kids are doing right now. Okay. But the idea would be that your conscious would be about Freud right now. The preconscious is immediately below the surface. So it's not the subject of your attention, but easily acceptable. So something like your phone number, your address, your birth date. So it's not what you were thinking of, but if I asked you about it, you could tell me. Then there's the unconscious. So that's where most mental activity actually occurs. That's what he believed. Those are our primitive feelings, our drives, our unacceptable urges, our memories, especially anything that is more undesirable. We kind of push to the unconscious level. And these things are more difficult to retrieve. They're not easily accessible. And so that's really what the basis of psychoanalysis was to help retrieve those things so that they could be worked through. He also believed that there was an inner psychic struggle that occurs in the brain among the different parts of the personality. Okay, among the different parts of the personality. So the id, the primitive pleasure-seeking part of the personality in the unconscious mind. So this is what we would, you think that, children are very much id. If you think of an infant, they don't really think about how they're, what they do, how it affects other people. It's just their immediate needs are what they think about, their pleasure. Okay. Ego is a sense of self and intermediary between the id and the world. It helps limits the id's impulses, which are all about self. And it helps the super ego not be too rigid, because the super ego is really all about your conscience, about what you should and shouldn't do. So it's the leader. It's the one that, balances things. It allows for delay and satisfaction. And it uses ego defense mechanisms to help reduce anxiety. And so when we talk about anxiety, we're going to talk about ego defense mechanisms. And that's also what you're meant to be putting each week on your mental status exam. The very last question are about those ego defense mechanisms. So we do want to make sure that we understand those. The superego, as I mentioned, is the constant conscience, the shoulds, the should nots, definitely influenced by caregivers, parents, because it has to do with morals and ethical standards. So it's what somebody believes is right or wrong. When we talk about psychoanalytic therapy, the goal is to relieve emotional disturbances by knowing that unconscious mind. So it takes a lot of time. So it's extremely time consuming and therefore tends to be very expensive, because those people that still use it, are trying to dig into people's unconscious, their past, early traumatic events, stuff like that. So some of the ways that some of the modalities that they utilize include things like dream analysis. So you can imagine that's probably pretty subjective. Free association. So that takes analysis by a therapist to search for forgotten, repressed memories. But basically, free association would be, I would say, a word. And then, so I would say light, and you would say the first word that came to your mind. And so you might say dark, you might say day. And so depending on what you said, that's interpreted differently. So again, very subjective, not often used anymore. Oh, it's a puppy. Transference is safe expression needed for successful therapy. So transference can be a problem if it's part of the nurse-client relationship. And so this is when, can we mute? See if I can. Sorry. There we go. Okay. So transference is when the patient transfers like feelings onto the therapist. And so the therapist may use that. So if somebody's an actually trained therapist, they might utilize that to allow a patient to work through some of their issues. So if I have an issue with, let's say my father, who's an alcoholic, and let's say that he was deceased, but I needed to work through the fact that he was abusive and that he, was not at all nice and didn't take care of us or whatever it may be. Then I could transfer those feelings onto the therapist and work through it almost like the therapist was my dad. So there are times when that's utilized because there's how else is that person going to work through it when that person's no longer alive. Now, where the problem lays is if you're talking about it in the nurse patient relationship. So we do not want transference, or what we're going to talk about next, countertransference, is in the nurse client relationship. It interferes with our ability to stay, more neutral and empathetic. It would cause more, sympathy or other issues. So countertransference must be brought to the surface and addressed so that the client is not harmed. And this is where the therapist or the nurse projects feelings onto the patient. So it could be something along the lines of, let's go back to the scenario with my dad, that I have a patient who reminds me of my dad. And so I'm not very nice to that patient, or I go out of my way to kind of avoid interacting with that patient. Or it could be the opposite. It could be that a patient reminds me of my sweet grandmother. And so I spend extra time with the patient. I'm not, again, not fair, not neutral, or empathetic with the patient. We good so far? If you, okay. Okay, interpersonal theory by Sullivan. So this is the belief that personality dynamics and disorders were caused primarily by social forces and interpersonal situations. So according to Sullivan, really all behaviors aim to avoid anxiety and threats to self-esteem. So there's things that have to do with anxiety in this theory, but also a lot of interpersonal relationship issues are dealt with in interpersonal theory. So the belief is that healthy early relationships lead to a healthy personality, and also that anxiety can be transmitted through empathetic linking. And I think you probably all have experienced that. Anybody ever had anxiety transferred to them? Maybe before an exam? You weren't super anxious, and then other people get together and they're anxious, and then you become anxious, right? So that's a belief that has to do with this theory. Another one is that they kind of had the good me, bad me, not me. And so the good me was that the patient or that the person avoids anxiety by focusing only on their positive attributes. The bad me would be hiding the negative aspects of ourselves from others or even ourselves. So we don't focus on that at all. And the not me is that they can't even imagine something being a part of them. So they push it really far down into their unconscious. So again, this is where, we start to think about those unconscious thoughts a little bit. And this is where it gets kind of Freudian in nature. But the interpersonal therapy here, I think this is where we can where we utilize some of these aspects, is where the therapist actively guides and challenges maladaptive behaviors and distorted views, focuses on the here and now, which is what we do with patients all the time, to help patients recognize their dysfunctional patterns and modify them. So they get reassurance, clarification of feelings, and increased interpersonal skills. So just to share a little bit or make this more understandable, what this can help is our patients, if they can understand their dysfunctional patterns and how that interferes with their interpersonal relationships, then they can actually start to make changes. So I do groups on this sometimes. One of the groups that I do that kind of gets into interpersonal theory a little is something called the ripple effect. And so you have the patients actually visualize being around a pond, and that you make a choice. So you have a rock, and that rock is your choice. It's your choice and your behaviors. Okay. So if you have the patient and they throw the rock visually into the pond, it ripples out. And so you have a piece of paper that shows a pond, and it has like their job, it has their health, it has their relationships, it has like multiple different aspects of their life in it. And so you ask them, how does the most recent choice that you made, a choice that led to you being here in the hospital? So maybe the choice was not taking medications. Maybe the choice was using alcohol or drugs again. And you ask them to then explain, how did that choice ripple out and affect all of these different things? How did it affect your family? How did it affect your your job, your health, whatever? And you talk to them about that, and they can start to actually understand that their choices have consequences, which, as much as it's hard to believe, a lot of patients don't get that. They don't get how their choices, their dysfunctional patterns affect other people. So helping them realize that actually helps us be able to work on some of those patterns with patients. The one thing I always like to end that particular group with, though, is that, you know what, the ripples don't last forever, though. You're always making new choices. You always have a new rock. And so your next choice, if it's a positive choice, think about how that can ripple out and affect things and make things better. So I think that you always want to end on some sort of hope that it isn't just, you made bad decisions and that's the end of it. Okay, so behavioral theories, Pavlov, Watson, Skinner. You guys all know about Pavlov and his dogs, right? So this is about utilizing conditioning to shape behavior, and that involuntary behavior can be conditioned to respond to neutral stimuli. You guys have probably experienced this at some point in your life. So you ever have a neutral stimulus mind? One for me is soft pretzels. Okay. I got sick off soft pretzels one time. And I don't actually think it had anything to do with a soft pretzel. I think it was, I just happened to throw up that night when I was a kid. And ever since then, I can't do a soft pretzel with salt on it. Never. So, so like if you had coleslaw and then it made you sick afterwards, that would be taking a neutral stimuli and having a new response to it. So you get conditioned to do some of those things. I'm sure each of you can come up with an example of that. So behavioral therapy or behavior modification attempts to correct maladaptive behavior or responses by rewarding and reinforcing adaptive behaviors and generally ignoring the maladaptive. Okay. We use this all the time. Use this with children. We use this with patients. Where you acknowledge those positive things. This is where we would get into, instead of saying you did such a good job, this would be making an observation where I say, okay, I noticed that you made your bed today. I noticed that you showered this morning. I noticed that you brushed your teeth and your hair. So it's stuff like that where you're acknowledging it because you want it to be repeated. Now, a couple different versions of this systematic desensitization. This is promoting relaxation during anxiety-provoking stimuli so that the person can gradually face the stimulus. Okay? So the person can gradually face the stimulus. So I always give an example of this, and it always horrifies me to discuss. This can be used in phobias. Okay. So I have a particular phobia of spiders. Do not like them. Okay. And so if I was going to go through systematic desensitization to spiders, because for some unknown, god awful reason I had to hold a tarantula, okay, then I would go through systematic desensitization. I don't know why I would do this, but that's the example I'm sharing. So, so what would happen is very first I'd just picture in my head, I'd picture a spider, not a tarantula because I'm not there yet, but a small one, okay? And then I'd have anxiety, and then I'd have to, like, somebody would help me bring that anxiety back down. I do some deep breathing. I figure out, you know what, I survived visualizing that little spider. I can do this. So the next time somebody might give me a picture of a spider and I have to see this picture of a spider. Um, and so then I would go through the anxiety response, come back down. The next time, maybe it's a spider in a glass case. Same thing, anxiety, bring it back down. And then eventually I get up to the point where I'd hold the big, nasty tarantula in my hand and I would, I don't know, I'd probably die. But anyways, and I would be able to do that. Okay. So you can see how if somebody's like afraid of flying or afraid of elevators or they have phobias of these things that actually interfere with their day-to-day life, that they could use this with a therapist to try to help them overcome that phobia. Aversion therapy helps to get rid of unwanted habits by associating unpleasant consequences. So it's really a form of punishment. Don't use that a lot because we don't generally, use forms of punishment with patients. But that would be part of that therapy if somebody were to do that kind of outpatient for things. Biofeedback, this one, I don't know a ton about biofeedback, but I know that it is part of behavioral theories. But this is where people can actually learn to control their physiological responses through visual or auditory feedback. So, and using relaxation techniques to change them. So what somebody can do is actually, if they notice that their blood, that they have high blood pressure, the person can actually learn how to lower their blood pressure if they have readings and they see how relaxation actually helps. People can do this with heart rate. They can do this with brain waves. They can change their brain waves to be more calm brain waves. So it's very interesting, but you need kind of more specialized equipment and things because you have to have either visual or auditory feedback in order to be able to do it. Cognitive theory by Beck. So this is one that we did talk about with depression. So it's based on the belief that depressed patients have a standard pattern of negative and self-critical thinking. These cognitive appraisals lead to emotional responses. If you can change the evaluation, you can change the emotional response, okay? So this is where we look into those negative, you remember the triad? That I'm not a good person, it's not a good world, and no matter what I do, nothing ever changes, that type of thing. So that's what this is about. This is the same theory. So if we can help people identify the negative patterns of thought that lead to negative emotions, then help them replace those thoughts with more rational ones. So they have, the patients end up having like a schema, which is a unique assumption about the world, about themselves, about others. So this, another example of this could be that, let's say my mom left me when I was a kid and I ended up having to be raised by grandparents who then passed away when I was a teenager, something along those lines. So now every time I have a relationship and that relationship gets terminated, the person leaves, or, I feel like I'm getting abandoned over and over again. I feel like I'm not a good person. I feel like, nobody actually loves me. People are mean and uncaring, and that I'm just destined to be alone and abandoned the rest of my life. So that's where people will kind of have these automatic thoughts. So they're these rapid, unthinking responses based on that schema. So in this particular case, that schema would really be like abandonment. And then they have these cognitive distortions. So these irrational false assumptions and misinterpretations, that it could be something along those lines that, I'm not worthy of being loved, or nobody actually will ever care about me. And it's those false things that they get stuck in their head, and then they're repetitive and they're automatic. So as soon as somebody says they want to terminate that relationship, then they automatically jump to the fact, well, nobody ever loves me, those type of things. Does that make sense? I have a couple. Yeah. Okay. Okay, so just some reminders that we still use Maslow's, Erickson's in this course, so you still might want to think about these. I think that they are helpful when you're looking at prioritization. The one thing I do like to point out with Maslow is that um, you have to think about it in a slightly different fashion than maybe you do for med surge. So one thing is that safety is the second level, right? But for mental health, you almost have to think about a lot of the safety measures that we take as part of the first level as well, because they're meant to promote AIR. They're meant to promote that the patient still, lives and breathes and doesn't injure themselves. So it's hard to say that taking shoestrings away from a patient is a level 2 when really it's part of their suicide precautions. Does that make sense? Okay, so those two are a little bit more meshed together than maybe they usually are in med surge. The mental health recovery model, this really emphasizes hope and social connectedness, empowerment, coping strategies, meaning in life. And so what this model does, this is the model that I mentioned before that I believe is very much nursing centric, because it's patient centric. It's all about empowerment. And so this is the model that nurses have used without really ever calling it that. Excuse me. That we want patients to be able to self-administer medications, and we want to prevent relapse. Basically, we want patients to understand what's going on with them and why they're taking the meds that they're taking. So to me, that's all stuff that nurses do anyway. The last model that we really talk about here is the biological model. And so this is that mental disorders are believed to have physical causes. Therefore, mental disorders will respond to physical treatments. So this is really a lot about how our medications work. That's all based on biological theory. How ECT works, how a lot of those other treatments, the vagal nerve stimulus and magnetic resist, all that stuff, that's all based on biological model. Now the question here is, how do chemical balances come about, nurture or nature? What do you think the answer is?
Both.
It's both.
Yeah.
Absolutely. Because the nature part is that genetics, it's that genetic predisposition that a lot of people have. But the nurture part is what usually triggers those actual imbalances to take place. It's the environment. It's those traumatic life events that happen early, or the stressors that people have to deal with throughout their life. So it's really both. And I do just want to make a statement. Sometime I think I may have said this to you guys before, but I'm not sure. So just keep in mind that every thought that you have, every thought that goes through your head are neurotransmitters, right? You can't have a thought without neurotransmitters moving across the synapse. So does it make sense that medications help? They work directly on neurotransmitters, but does it also make sense that therapy helps? Because you're changing the way that you think. And so you're changing the neurotransmitters. And if you can change the way that you think enough, you actually change the neurocircuitry in the brain as well. So it's very interesting that we always think about physical things differently than we do, mental illness. But mental illness is just, it's not as visible in the brain, but there's still things that are going on in the brain. It's still physical issues that are happening. So I think it's important to keep that in mind. And that's why the next question we get to, that's why the correct answer is the correct answer. But biological therapy, so medications, as I said, and then ECT, which we've already talked about. So what is the best approach? The best approach is medications along with cognitive behavioral therapy. Okay, it's medication along with cognitive behavioral therapy. And that way the medications can help acutely while we're working on that neurocircuitry and changing those patterns in the brain as well. So if we're not therapists, why do you think we just talked about all those different theories and therapies? What are your thoughts?
You want to touch back on like what they talked about in therapy?
Yeah, we need to be able to reinforce because the patients, depending on what type of therapy they're in, they're going to be using some different strategies. And not only that, but we can pull strategies. It doesn't even have to be just the ones that they're using, right? But we can try to pull strategies from different theories to try to help those patients. Good, very good.
I think it also helps with like coordination, where like that whole team approach, where everybody's on the same page.
No, absolutely. I would totally agree with that. That way we all have a good understanding of what the patient's going through. Now, I did say that cognitive behavioral therapy is the best. I will say that a lot more are kind of integrating some of the interpersonal therapy in with it, just because so many mental illnesses cause issues with relationships. So they're usually pulling bits and pieces of that interpersonal theory in there as well. Okay, so the next part of this pack, page 61, 62, 63, there's not a ton of notes on this. There is towards the end a little bit of notes, but a lot of this is just so that you're learning some of the vocabulary that you might be seeing, especially with the medications. It's just kind of an outline of the different medications that you're going to see throughout the course. Okay, so you're not expected to memorize all of these, but you're going to learn them as we go through. I think next week we start talking about schizophrenia, so we'll get into the last major chunk of medications will be with schizophrenia, and then there'll be a few smaller bits of information on meds. So you'll see that it has the different types of antipsychotics. Sometimes it's helpful just to see how they're categorized. So that's why I like this outline. And then, because you have your typicals and your atypicals, then you have your mood stabilizers, you have your antidepressants, the different types there, which we've gone through. And then towards the end of the course, we'll talk about the anxiolytics or the anti-anxiety medications. There's a combination drugs. I don't usually talk about those a whole lot. So if we look at page 63, if you look at page 63, it talks a little bit about pharmacogenetics. And these are inherited differences in metabolism and response causes differences in metabolism of some medication. So that's a lot of words to say that your genetics can play a role in how your body metabolizes your medicine, okay? So different people are going to respond to different medications in different ways. So that's why some people have, really good responses with certain antidepressants and other people don't. And they need to be on a different type of antidepressant. That's part of it. Also, I've seen this, and they do this a lot of times in outpatient care. I've seen it through the Zeph Center, which is down in Toledo. But they draw blood, they send it out, and the lab will actually come back and say this person metabolizes these types of antidepressants or specific names of antidepressants well. These ones they don't metabolize very well, and so they kind of give them like a yellow, like caution. So you have green, yellow, and then they have red. Like this person, these medications are not going to work with this person. They're going to have too many side effects. They're going to have, whatever. And so it actually tells you, individualized to the patient, whether or not they should be taking these meds or which ones they should be taking. And I could tell you for me personally, I take phenytoin for pain. It's an anticonvulsant, Dilantin. You may have heard of Dilantin. The generic name is phenytoin. I can only take it from one manufacturer. If I get it from a different manufacturer, there's something in it and my body doesn't metabolize it and my level goes to 0. So I have to make sure every time they fill it that it's by a certain manufacturer. So it can be that specific, the way that your body, metabolizes medication and stuff. And so this is a really good, it's not something that they do across the board for every patient at this point in time. But if you have a patient that's not responding very well and they're trying a few different meds, this would definitely be something to bring up is, can we do some specific testing to see, if this patient is like burning through their meds. We had a patient who had very severe bipolar disorder. She'd come in extremely manic, and then she'd come in like catatonic at times. She was a little bit older adult, and they finally did some genetic testing. This was 10, 15 years ago, so this was very new still, and they figured out that she metabolized whatever anticonvulsant she was on. She metabolized it extremely fast. So here she was getting a normal dosage of it. She was burning through it so fast that it wasn't doing anything. So they figured out she needed to be on, a combination of meds or different meds, and it was very helpful. Cultural considerations, so again, may affect the above. So some cultures may genetically be predisposed to certain either metabolizing through things or not being able to metabolize certain things. Or it can just be the cultural differences can be how they view medications or even how they view mental illness, truthfully. Client care guidelines here, assessment. We always want to know about their past and current meds, the side effects, and their views of taking the medication. Do they feel like it's important or not? Coordination, we help with coordination. So making sure that the patient has appointments set up and that they can actually get to the appointments. That's important. That they have the ability to take their medications and any issues with adherence. And whenever I talk about adherence, I think it's really important to differentiate whether or not the patient is, like if they're not having good adherence, are they a cannot or a will not? So is it somebody who cannot take their medications because they can't afford them? They can't coordinate it. They don't have the memory or the capacity to recognize when they're down to 2 days worth of pills that they need to call and get it refilled. So the cannots are usually the people that we can work with. We can try to get it auto refilled for them, sent to their house. There's all these things we can do. Or they will not. I will not take this medication. I do not believe that I need it. I do not, and that's where we can try education pieces, but the will nots are definitely harder to work with sometimes. And then drug administration, we always are monitoring for effectiveness, watching for cheeking. Patients will cheek their medications, and then you have to figure out, are they cheeking it because they don't want to take it? Are they cheeking it because they're trying to hoard it so they can take an overdose all at once? So there's different reasons that a patient might, cheek their medications. But patients are very, very creative. I went up to that forensic unit, and they were telling about patients that were able to cheek the dissolving medications. So even though they're supposed to dissolve right on the tongue, they would take like the half hour before and just keep sucking all of the saliva and stuff out of their mouth so that it was dry, and they get it to like stick up in the side of their mouth, and then keep it there for a half hour because they're monitored for a half hour after they take their medications, and then pop it out. So to keep a dissolving medication like that, that's kind of amazing. Not really a good thing, but kind of amazing anyway. Okay, are there any questions over the treatment modalities, theories, that information? No? Okay.
I have an unrelated question.
Sure.
So for the syllabus, it says that this was the end of our stuff for exam 1. Just so I can break up my notes. Would this be the end of the stuff that we need to know for when we get to take our exam 1, and then
Yes.
we start anxiety for exam 2?
Yes. That's
Okay.
correct. Yep. Good question. Any other questions? Okay.
How do we rewatch these?
So I have them posted on Brightspace.
Okay.
So I just have the recording. You might, for this one, you might have there's probably 5 or 10 minutes of just us chit chatting in the beginning, so you can fast forward through that. But
Okay.
because I don't know how to splice them.
That's okay. Thanks.
Yep.
So are these going to be available to us like during the summer too? Because I know like Brightspace, once the class ends, like everything, all that content goes away. So,
Yeah. I've already requested, as of right now, that we just had to stick a date in. I think I stuck June 1st in or something. I mean, not that I have no idea when we're coming back, right?
Right.
But I just had to stick a date in, and I work with Jeff Peters, who is our coordinator for online learning. And he said, whenever we, just tell him a date, and whenever we come back, we'll have it available through them.
Okay, cool.
Okay.
Thank you.
You're welcome. Any other questions or things I can help with, clarify?
Anxiety is considered on this exam too, correct?
No, this is the start of exam 2.
Oh, this is right now.
Yep, anxiety, just
Oh,
anxiety.
anxiety.
So
Okay.
everything for exam 1 was everything that we've done up to this very moment.
Okay.
Okay. Anything else? Okay. Something else comes up. I don't think this will take a real long time. You guys probably, did you guys look at this yet? Did you try the matching? Okay, then we'll be able to go through the matching. That's good. Okay, cool. Okay, so anxiety is something that you have all experienced. It's a feeling of apprehension, uneasiness, uncertainty, or dread resulting from a real or perceived threat whose actual source is unknown or unrecognized. So what are some things that I'm going to ask you these questions so you can unmute yourself, but what are some things that we associate with anxiety? So let's first talk about triggers. What are some triggers for anxiety? Yes, COVID, for
Right.
sure.
Rona.
School,
School,
bills,
Exams.
bills, exams, right?
Crowded
So
places.
what was that, Lisa?
Crowded places.
Crowded places, yeah, right now for sure, right? In general though too. So we think about triggers, and then some other things that we might think about. If I just asked you, what do you associate with anxiety? You could also come up with some symptoms. So what are symptoms of anxiety or feelings that you associate with anxiety?
Sweaty palms.
Sweaty palms,
Elevated heart rate.
increased heart rate,
Lack of focus.
lack of focus for sure.
Chest pain.
Memory.
Chest pain, decreased memory. I think that's what somebody said.
Increased breathing.
Increased
like,
respiratory rate. Vital signs.
Hyperventilating.
Yep.
Yeah, hyperventilating.
Muscle tension.
Say that again.
Muscle tension.
Muscle tension, yes. I cannot be the only person who, the more anxious I get, the more my shoulders end up here by my ears. And I'm like, whoa, I'm a little stressed, I can tell. So, that constant trying to work that out is fun. Okay, very good. So, do we need anxiety?
Yes.
Yeah.
Yes, unfortunately we do, right? So, why though?
It's like a response to danger or
Anxiety is a response to potential danger, for sure.
motivation.
Motivation, yes. If you didn't have a little anxiety about school, would you necessarily have gotten up and got on this Zoom conference?
No.
No, right. So it drives us to complete activities. It drives us to try new things. My anxiety about how we were going to complete this class forced me to become okay with recording myself. So there's that. But if we didn't have at least a little bit of anxiety, we'd never get out of bed. Okay? We'd never get things done. So what's the difference between acute and chronic anxiety?
Acute anxiety is normal and expected for stress and eventually goes away, but chronic, it's kind of always there.
Okay. So it can continue on even after that stressor may be gone. Or, well, it can continue on even in the absence of that trigger, or the trigger can be something that happened so long that it causes constant anxiety, or that chronic anxiety. And so the outcomes of it can be that there's a lot, there's comorbidities then. So long-term stress, I don't know if you remember from fundamentals, but long-term stress can cause all kinds of havoc on the body. There really isn't a body system that long-term stress isn't going to affect. Why do we need to understand anxiety?
1 in 4 people have anxiety.
Say that again, Maria.
And 1 in 4 people have anxiety.
Well, 1 in 4 people actually have anxiety issues, but how many of your patients do you think have anxiety?
All of them.
All of them.
Everybody has anxiety.
Right? You're taking them away from their home. There's things that they don't understand that are happening to them. They're away from family. I mean, pretty much, you're absolutely correct that anxiety disorders are extremely high. And I'm sure that the rate of anxiety disorders right now is even higher. But everybody who's in the hospital, unless they're unconscious, right, has some sort of anxiety that's going on. And so we help our patients through it all the time. Okay, so we have different levels of anxiety. And so you should be able to differentiate, especially mild and moderate from severe and panic. Okay, even if you can't differentiate mild from moderate real easily, I'm going to try to help you do that. So if you were given a scenario, you could figure out which level of anxiety that they had. Okay, so mild is normal everyday life. This is actually a little bit of anxiety is helpful. This is actually the level I want you at when you go take a test. Okay, because it sharpens your perception, it helps you be more focused, it helps you problem solve better. You might be a little bit restless or irritable. You might bite your nails while you take a test or something, but overall, cognitively, you're actually sharper. So an example for this could be a classroom exam, okay? Now, I'm gonna give you some examples, but what I want you to understand that the level of anxiety goes by symptoms, okay? So you can have, the same thing. So I could say getting my blood drawn for me just causes mild anxiety. But there may be some patients that if I told them if I told my daughter she was going to get her blood drawn, she's probably going to be at least at moderate. Okay. So the trigger for it is going to be different for different people. Are we good with that concept? Okay, good. Okay. So moderate anxiety is where perception narrows and some details are excluded from observation. So less information is processed, there's some selective inattention, thinking and problem solving is lessened. Support from another person is very helpful. Okay, support from another person is very helpful. So highlight or underline that. Symptoms include tension, tachycardia, tachypnea, perspiration, GI discomfort, headache, urinary urgency, voice tremors. So once again here now, we went from kind of peak on cognition to now we're lower, okay? So this is problematic at this time. An example of this, as I mentioned, could be like a minor procedure, like an epidural injection or something. So now we need to think about mild to moderate interventions. We can usually, at these levels, we can usually talk the patient down, okay? We can help them explore issues and different outlets. we want to keep an eye on those nonverbal cues. We can help them identify triggers and problem solve at this level. So the patient, even though they're not the best at problem solving under moderate anxiety, they still can with some direction. And what do we need to do? What do we need to remain?
Calm.
Calm. And what type of environment?
Low stimuli.
Decreased
Stimuli.
stimuli, for sure. Good. Okay, now we get to severe and then panic. So severe is greatly reduced perception, can focus on like one detail or like scattered all over the place. They have problems recognizing what's going on in their environment, even if somebody points it out to them, okay, because they're not focused on what is happening at all. Here's where they can actually have confusion. So if your patient starts to be confused about what is happening, that's really the marker for severe, okay? That's the big difference. They can hyperventilate, have sense of impending doom or dread, but that confusion is by far the way to mark that somebody's in severe or panic level, okay? Examples of this could be maybe waiting on a biopsy to come back, or having an invasive surgery, having a patient who is extremely ill and on a ventilator. I mean, all these types of things could happen here. So panic, the person has markedly disturbed behavior, unable to process environment, symptoms and behaviors, shouting, screaming, withdrawal, hallucinating, impulsivity, uncoordinated, erratic behaviors, all can lead to exhaustion. So this is somebody, I mean, you think about a disaster, okay? Somebody who is just completely out of control. And so that's when I think of an example, I think of somebody that I might encounter during a disaster type of situation, okay? So the interventions, of course, remain calm, reduce stimuli, but what's our number one concern? If we have somebody who's confused or impulsive, safety, absolutely.
Safety.
100%, it's keeping this person safe. So this is where we may need to take a very firm directive approach. Clear, short, simple communication. And then anytime that we're working with patients who are more confused or we can't understand exactly what they're saying, we look for themes. So this is where we would look for themes in their communication. And we reinforce reality. So I'm Nicole, I'm your nurse, I'm here to help you. I need you to come with me. I need you to sit. I need you to take a deep breath. I need you to try to focus on my question. It's that type of, it's a very calm, direct approach. Remember that this person is not able to problem solve. This is not a time to be, asking them a bunch of, giving them a bunch of choices and things. At this point, they likely need medications or even seclusion. They might need to be by themselves for a little bit. I mean, it just depends. But this would be a time where you might have to give somebody medication without their consent, is if they're, all erratic and things. We need to make sure that we're maintaining their physiological needs like fluids and calories also.
Noah, turn off YouTube videos.
So they would need, this at this level, the severe to panic is when we start medicating people without necessarily their consent. Now not so much at mild, but at moderate, if I could tell somebody was starting to elevate and they have a history of going into more severe levels, then I might offer somebody a PO medication. Whereas if they're in panic, they might be held down and given an IM against their will, okay? Does that make sense, the differences there? Okay. Okay, we will go through the defense mechanisms. And then we're actually done for this morning unless you have any questions, okay? Because tomorrow we have addiction. Addiction will take a a little bit of time. So, okay. So healthy defense mechanisms. We have number one, or did anybody come up with what regression and introjection are? What's regression?
Isn't it like returning to an earlier stage of behavior?
Yeah, so one of the classic examples, good Kristen, one of the classic examples of regression is like having the 4-year-old child and bringing home the new baby, and the 4-year-old regresses to being no longer potty trained because they see all the attention that the baby's getting and stuff. And then introjection. What was that?
You adapt someone else's feelings as your own.
Yeah, so can anybody think of an example of that?
Like parents and children, like what a parent interjects their thoughts or feelings or opinions onto their children, and then the children believe it.
So if I tell Lily every day,
you have a call on 70.
Sorry.
that's okay. So if every day I tell Lily that she is the smartest kid I have ever met, okay, and I tell her that and tell her that and tell her that, do you think eventually she's going to think that she's the smartest kid in the world?
Yeah.
Yeah. Yeah. She's pretty smart, but I don't know about the smartest kid in the world. But but you can see how that can set kids up to think that they're better than others and stuff like that, you know, so you have to be really careful about that. Okay, so
Can
it
you
would be
repeat the definition for regression?
I'm sorry.
Can you repeat the definition for regression?
It's going back to an earlier stage.
Thank you.
Yeah, you're welcome. So what I was going to say is that it would be like Lily would be the one that would be interjecting, right? Because she would be taking what other people think of her and making it her own feelings. Okay, so healthy defense mechanisms. We have number 1 is D, 2B, 3C, 4A. So if there's any, I want to go through these just by category here. If there's any of these that you need further explanation on or you missed, just let me know and we'll talk about it right now.
Can you repeat it one more time?
Yep.
Sorry.
D, B as in boy, C, A. We okay with those? Because you got to be able to use these every week on your mental status exams, okay? Intermediate defenses. 1, B as in boy, 2, D as in dog, 3, F, 4, A, 5, C, 6, E. Any of those confusing? We good? Yes? Okay. Okay, immature defenses. So these unfortunately are some that we do tend to see in our patients. So number 1 is G, 2 is H, 3 is E, 4 C is in cow, 5 F, 6 D is in dog, 7 B is in boy, 8 A.
So I got, I guess, let's go with 3 and 5. Those were confusing for me. I don't know about anybody else.
Okay, so idealization and splitting.
Yes.
So idealization is idolizing, kind of. Okay, so it's only thinking about the positive attributes of a person. Splitting is a little bit different. Splitting is where you think about both attributes of the person, but not at the same time. So the person is either good or they're bad. Okay. When you actually see splitting a lot is something that we call staff splitting, where they pit the different like nights versus days. They'll pit them against each other. Well, night shift always lets us do this, and I don't know why day shift is always so mean, and you guys don't let us do anything. And so it'll be, day shift said that we can blah, blah, blah. And so this is where consistency comes in, is really important, but they're kind of, it's that splitting, and everything is like black and white instead of seeing the gray that in reality everything is. So does that help, Deb?
It does. Yes. Thank you.
Okay. You're welcome. Any other ones? Nope, nothing else? Okay, now don't forget that you do have your case study. I did post it. I posted it early. I know a few of you have already looked at it and done it. I'm not going to grade it until a little bit later. So I might not grade them until Friday, but that case study that's due Friday is available. And then we'll have our Zoom lecture over addiction tomorrow. And then you'll have your virtual clinical. It'll be a patient with depression. I actually have it here, and that's what I'm gonna be working on the rest of the day. Is Charles and I are working on we have a video. We're working on the extra information that goes along with the video, so you guys can actually complete a care plan or concept map, whatever you want to do. Do you guys have any questions about that? I know we kind of took this week, and we're trying to make sure all the clinical instructors are on the same page, okay? But
can you go over the weekly evaluation, what you meant by what you posted?
Yeah, so the rubric, the weekly evaluation rubric, I didn't have that as a fillable document. It was just, it was electronic, but there was no way for us to fill it without everybody being able to scan it.
Okay.
So Rachel, I think I haven't looked at it yet. I was gonna look at it today. Rachel turned it into a fillable document for us. So what I was gonna have the instructors do, was fill it out and then give it to you guys so that you can see what you're getting evaluated and what you're not, right? Because we can't meet every outcome virtually. And then let you guys just reflect on the ones that you need to reflect on.
Okay.
That way you guys could do your piece. Now, I did just get an email that says Charles was having difficulty with using it, so maybe it needs a little bit of work. So that's why I just wanted to let you know that we're behind on those.
Okay. That was my question too. So
yeah, we just didn't have them electronically. So
yeah,
we had to create that. Or fillable, I should say. We didn't have them fillable electronically.
Some people got their case study back from their clinical instructor. I have Charles and I still haven't, so I didn't know if he just hasn't got to that yet or if something's.
Which case study do you mean?
Like the one that was due on Friday for the virtual clinical concept map one.
Okay,
I got mine back.
So if you're talking about a concept map, then that was turned into your clinical instructor, and he may still be working on that. If you're talking about what was due Friday at noon, that was the depression suicide case study. That was due Friday at noon, and I graded all those Saturday morning and turned them back.
I don't know. Maybe I'll just email you, I guess, because I don't think I did that. I didn't get anything back from you either. So I don't know where I missed that.
Yeah, email me and we can see. Or actually, if you want to stay on, I'll stop recording here in a moment.
Okay.
Are there any other questions for the group?
No. Do we have ATI video things again to do for clinical this week?
Yes. If you look at your schedule, so this schedule, I don't know if you can see it.
Yeah.
The second page is everything to do for clinical.
Well,
oh, okay.
Are you gonna open those early again so we can do like the video recording and stuff before like our clinical day?
They're already open.
Okay, cool.
The ATI is already open. I'm working on the case scenario today with Charles.
Okay, thank you.
Any other questions for the group? Autumn, I want you to stay on, okay?
All right.
I did have one question.
All right, I'm gonna stop recording then.
hey, how do we do the
Columbia Suicide Scale? Is it like a point system? Like all we got was the piece of paper like the first day, and then you said we would go through it more in class or on clinical, because like you just check boxes like.
Yeah, so it's those two. It's the one that you're doing. I don't know if you can see. Is this one?
Mm-hmm.
So what I want you to do is, because we're not doing these on patients, is you just follow the directions. So I just want you to run through it once, actually asking the questions out loud to another human being. So whether you do that via Zoom to another classmate, you can do that. If you have somebody an adult in your household that you're comfortable with asking those questions, but I want you to be able to see their faces, and I want you to be able to work on your facial responses as you ask these questions. But Jules, to answer your question, it's just, you might have to read through it first, but just follow the directions. It tells you which boxes, where to go based on what they say. And if you can have that person, if they're comfortable with kind of making up answers to it to make it a little bit more realistic, that's even better.
Okay.
Okay.
I have a question. Is that just for your clinical group or for the whole class?
Every clinical group is doing this.
Oh, every clinical group? Okay. So do we get information from our clinical instructor about that? Because I haven't gotten anything about that.
No, that's in your practice. So your schedule that tells you everything you're supposed to do for clinical,
okay.
That's where that is.
Okay.
Okay. I don't have the turn-in places yet. That's what I'm working on today.
Okay.
Okay. So when you open up, hopefully I'll have it open tonight. When you open up if not tomorrow morning, okay, when you open up your folder for clinical day 2, it'll have like a turn-in spot for each thing. Okay, just like week 1 did.
All right.
Okay. Any other questions? All right, I'm going to stop recording.